My patient case study is about Mr. W.N., a widowed 82-year-old male, lives home alone, has 7 children from ages 27 to 55, no known drug allergies, worked in the coal mines for 20 plus years, has black lung. He went to his primary care physician with complaints of shortness of air and chest pain after walking to his local McDonald's. Symptoms stopped after waiting for about 30 minutes and sitting down. He had complained of similar sensations walking his dog and things like that before. He also had stated that he had chronic chest pain 3 to 4 times a year. He'd have to be hospitalized for similar issues, walking around and movement. But denied any use of nitro. So primary care had sent them to an outside hospital. At the outside hospital, an echo was performed and showed that he had a pericardial effusion. There, they showed the troponin levels were negative, and all signs and symptoms for a myocardial infarction were negative at that time. The outside hospital wasn't equipped, so then he got sent to our hospital, at which point we did a repeat echo, showed his ejection fraction was 20 to 25%, and confirmed his pericardial effusion. At that time, they started him on oxygen at 3 liters, and started him on low pressor and Renexa, and then transferred up to the cardiac progressive floor. He had had several asymptomatic runs of VTAC, lasting anywhere between 4 counts to a minute, and completely asymptomatic, maybe complained of a small palpitation, and the team was hoping that if we got rid of the pericardial effusion, that this would also subside with his VTAC runs. So the very next day, they performed the pericardiocentesis. 750 mLs of yellow fluid was pulled off. Patient was sent back to the floor, and about 5 hours post-procedure, he started complaining of chest pain, 10 out of 10. He became hypertensive, 167 over 102, which was up quite a bit from his baseline, and some nausea. An EKG was performed with no changes noted from the baseline. Morphine was given for the pain. Oxygen was increased to about 5 liters per minute, and he was given aspirin, and then labs were drawn. The troponin levels showed that they were bumped, indicating a possible NSTEMI, at which time they initiated a heparin drip, and he was transferred to the ICU. He had actually sustained 5-minute run of VTAC, and that was part of the chest pressure, and then after that they had started an amiodarone drip per protocol. So he had a suspected NSTEMI, and he was scheduled to get a left cardiac heart catheterization the next day for the possibility of any treatment or seeing if there was any other blockages or any other issues. He had a past medical history of chronic systolic heart failure, coronary artery disease, status post percutaneous coronary intervention. He had a couple of cardiac stents placed back in 97. COPD, chronic kidney disease stage 3, black lung, ex-smoker, 30 to 40 pack year. Currently uses chewing tobacco, and very nice because he offered me some. Head GERD, BPH, peripheral artery disease, hypertension, and hyperlipidemia. Pretty standard cardiac history. Also had an adenoidectomy, tonsillectomy, knee surgery, and a AAA repair in the past of unknown times or dates. When he came up to us originally from the ER, he looked like there was literally nothing wrong with him. He had 3 liters of nasal cannula going, and that's about it. Normocephalic, atraumatic, extraocular movements were intact, unlabored respirations. He did have a little bit of an expiratory wheeze, which was very expected with having his black lung history. Heart rhythm and rate were good, except for those occasional runs of VTAC. But again, asymptomatic. Abdomen equal sounds in all quadrants, non-tender, non-distended, no organomegaly, denied any abdominal pain or nausea at that time. No issues with legs, arms, everything, peripherals, all felt good. Pulses were good. No clubbing, no edema. Motor strength was good. So when he came up to our floor, he was doing okay, except for, he has like an extensive history of cardiac issues. And basically like having the heart failure, coronary artery disease, past medical interventions with the stents, the kidney disease, smoking, and the continued tobacco use all put him at higher risk for having a heart attack or an NSTEMI. And then when he actually began to complain of that 10 out of 10 chest pain, the nausea, the elevation of cardiac markers, the dysrhythmias of the VTAC, those are all, kind of classic signs and symptoms of having a myocardial infarction. And the thing is, with the EKG showing no change from baseline, that's what led us to believe that it was an NSTEMI as opposed to a STEMI without seeing that ST elevation. So he had the EKG with no ischemic changes. We gave him the morphine, aspirin, increased his oxygen, which is, standard Mona procedure for any suspected heart attack or myocardial infarction. They started the heparin drip after a suspected MI. We did the close monitoring of his PTT, and at my hospital we do the anti-10A when we start a heparin drip. So that's done, baseline every 6 hours, blood work is drawn, and then that heparin drip is done based per protocol. And then he was, to look out for bleeding issues. And then the fact that he had the 5-minute run of VTAC is when we would start an amiodarone drip and then do that per protocol as well. And then basically we were just waiting for the left heart cardiac cath to see what other interventions could possibly be needed. Whether it would be, he's ballooned or stented, or if they thought he needed a cabbage, whatever the case was, to prevent further issues. But him being an 82-year-old male did not put him at a really good, as a good surgical candidate. So we are actually pretty limited in what type of interventions we would actually be able to do. Last time I saw him was in the ICU, like the very next day, and he was like, oh, everything's fine, and he's a wonderful man. His family was there and asked tons of questions. Of course, we focused a lot on trying to cut down on tobacco use, but unfortunately, he won't. He's 82 and he's going to do whatever he wants. But some of his other family members had seen what the issues were, expressed concern, and we gave them some other stuff. So it wasn't just helping the patient, but also helping the family and treating them as a whole. And hopefully some of them can go out and get some of the help to maybe not have some of the same issues that their father has. But hopefully I'll be able to check back up with my patient in the future, because he was like the sweetest little old man ever, and I loved him to death, even though he kept saying, if Lord's going to take me, he's going to take me. So